Somehow we got it to work. It just worked. What did you do? I'm curious. It's working. Thank you.
I don't think you have the correct, Windows.
What did you do? Because I want to know.
Yeah.
I don't wanna like go back and like disconnect it.
I just want to see the video.
So we went to
You went to call
yeah.
and I think you maybe just didn't select the correct,
Which one did you select? It's okay. You can go back in and just look. We can look at it.
I think you went for KPAT Teams.
And
Not
it
sure.
should be KPAD Zoom.
Yes.
That's what I did. Thank you for letting me. Yeah, perfect. And then I can share screen. I know how to do that. There we go. Thank you. Yay. All right. Yeah, I'm old and I struggle with technology, but don't judge. All right. So we're gonna, my plan is to be done by 12:30 with both lectures. That sound like a plan for you? So if you want to eat snacks, do whatever. We're just gonna go, we'll take a break. We'll just bomb and go down by 12:30 and people can get on the road, including me. All right. Yeah, including me. I live really far, so getting on the road is important, but we'll get the, most importantly, we'll get the information presented to you so you can understand. Have you had any information on malignant hyperthermia yet? I'm seeing yes. Can you tell me what you've had? What information had you had about it?
No information.
But it's
Genetic disorder?
a genetic disorder. Indeed it is. What else?
No inhalation, yes.
No inhalation agents, and then no also. So you guys got that. Excellent. What else about it? Can it cause the death of a patient without being rapidly identified and treated?
Yes.
Would you know how to identify it? You're not going to be actually doing that, but you're going to be helping in the resuscitation. Yes, sir.
Raising temperature and high end-tidal CO2.
End-tidal CO2, excellent. End-tidal CO2, most reliable sign. This is going to be easy. This is going to be review for you. I'm also going to want you to understand the pathology. You don't have to say it on a test. It's not going to be on your boards. But remember, my focus is always, if you don't understand it, understand what this is, basically you've memorized a whole bunch of different facts. And in the future, when you graduate, you'll forget everything. So I want you to understand what this is, why it occurs. Why can't you give sucks? Why can't you give an inhalation agent? How does dantrolene work? All of those are part of remembering this whole process. Like I said, the good thing is it doesn't happen often, but when it does, it is a true emergency. And when it is a true emergency like this, who manages it? Anesthesia, and that includes you. You are part of anesthesia. We will be depending on you, okay? Tony and Sarah in the future are going to be going over everything you need to do in greater detail that I know with the anesthesia machine. Because she said you can't give inhalation agent. How does MH become triggered? By giving either succinylcholine and inhalation agent. So once I've been giving the agent, it's in the machine. The molecules of the agent are in the machine. Once I determine someone has MH, I don't want them to get any more of that chemical. How do I make it stop? We'll talk about it. I'll show you what we can do, but who knows the machine better than anybody else? You, better than anybody else, okay? All right, so let's start. Malignant hyperthermia. Malignant is a bad word, right? That is associated with suffering, death, all of it. Hyperthermia. What does hyperthermia mean?
High body temperature.
High body temperature. Good. These are objectives. Yeah, I don't like objectives. All right. So what is a hypermetabolic state? Question, and this is one of the best ways that I've ever come up with to explain this. You guys exercise, right? You know why? Because you're part of Kaiser and you need to thrive. So you exercise. When you exercise, what happens to you? What happens to your body? Do you breathe faster? Do you get warm? Do you get hot? Like if you exercise a lot? Okay. What about your heart rate? Does your heart rate go up? Yeah. Okay, good. As you're working your big muscles, right? Has anyone exercised to the extremes, like doing sprints and stuff like that? In any human being, you can exercise, but even in the most trained human, there is a point to where exercise is so extreme, everybody will stop because it simply hurts too much, or your body cannot keep up with the metabolic demands and you will lose consciousness, right? What do you've heard of people running in races or pushing themselves to the extreme? What happens? They get dizzy, they lose consciousness, they puke. That's the body's way to say, stop, no more. And as you stop, the amount of oxygen the body needs is less. Heart rate starts to fall, breathing starts to fall. It starts to reverse itself. Ready? MH is the most extreme exercise you could ever do. But you can't stop because the muscle tension and contraction, which is the disease state, is not controlled by your brain. When you exercise, you can stop at any time. The brain will tell you, I've had enough, stop. But in MH, the muscle contraction is not controlled by your brain. It's controlled by the muscle pathology associated with the agents, which we're going to talk about. So do you understand that? Hypermetabolism. When you exercise, you're hypermetabolic. If you have MH, you're hypermetabolic. Last thing, what is your body screaming for if you're hypermetabolic? In a hypermetabolic state, what does your body need?
Oxygen.
Oxygen, and what'd you say? And energy, that's right. So you need oxygen to be efficient at creating energy. In this case, ATP, right? You guys know that. Are we good so far? In humans, MH is most likely triggered by our anesthetic agents, period, end of story. And it's those two. So can we give narcotics? Yes. Can we give dexmedetomidine? Can we give vasopressors? Everything is fine. With the exception of, let's review, inhalation agents, right? So can I give SIVO? Okay, but how about if I don't give SIVO, can I give ISO? Can I give DES? No, it's all three of them. We cannot give any of them. And succinylcholine. How about rocuronium? Can I give rocuronium? Yeah, it's a paralytic, but it works in a different way. All right. We're going to talk about what ryanodine receptor dysfunction is because that's the key. That's what starts this disease process. It's what causes the muscles to contract and not stop. Your brain is not under control of this ryanodine receptor stimulation. And as you guys said, why is there receptor dysfunction? Because it's an inherited genetic disorder and can result in death if it's not treated quickly. So think about yourself, think about your body. You guys are healthy young people. Think about most extreme exercise you can do. What is your heart rate? You're running, you're sprinting. What's your heart rate?
140 over.
140, 150, 160. For you guys, that's perfectly fine. Now, at some point, you're going to stop. How long can you sustain a heart rate of 160? You healthy people. Long periods of time, but not forever. Now, take our general surgical population. Are they all healthy young people? No. So therefore, the longer this goes on in terms of not treating this disease, especially if someone has other pathology, they're going to do really poorly really quickly. So let's talk about, I told you this is not on your test, but I wanted, and you guys already seem to know the pathology and why this occurs. Pieces of it, but let's talk about it. So someone already said patients become hypercarbonic. You already said we need cellular energy, ATP. You already said we need oxygen. It's all there. All right, so let's start at the very beginning. I'm gonna narrate. Can you see the cursor? Where's the cursor? Oh, there it is. There we go. Okay. No MH. This is just normal physiology. I want to move my arm. My brain says, move my arm. So a signal gets sent down my brain, right, from my brain, down my spinal column, out to nerves, to this nerve. This happens to be a muscle cell, one cell that makes up muscle. There are millions and millions of these, this is just one. So here we are, and I have an action potential. I want to move my arm. The action potential comes down here to this particular receptor. And you'll notice this receptor here is called RY ryanodine. So remember on the first page, it says that MH is caused by ryanodine receptor dysfunction. That is a ryanodine receptor. Okay. Under normal conditions, normally, when I want to move my arm, what needs to happen is, in order for muscle contraction to happen, calcium needs to interact with muscle. Without calcium, muscles do not contract and relax. So I want to move my arm. Calcium comes out of this organelle, SR. You can memorize it or not, I don't care. You've heard it, sarcoplasmic reticulum. Inside the cell, it is a reservoir for calcium. I want to move, stimulation, calcium release, interaction with muscle, muscle contraction. I want to stop moving my arm. I'm done. What happens is this action potential stops. Calcium then moves from the muscle back into the sarcoplasmic reticulum. And the calcium is in here, it cannot interact with muscle. And therefore you don't have muscle contraction. You understand that normal physiologic process? Good, okay. So let's throw so what is MH? How does it work? Ryanodine receptor dysfunction. So what happens is you give sucks or you give inhalation agents. And for whatever reason, the ryanodine receptor is stimulated in a pathological way. Massive amounts of calcium, doesn't matter about an action potential. Brain and nerves have nothing to do with it. The pathology is here. Massive amounts of calcium come out and interact with muscle, which is why the overall pathology associated with MH, it all stems from sustained muscle contraction, skeletal muscle contraction. Not only does a massive amount of calcium come out, massive amount of calcium stays out. And as calcium interacts with muscle and stays out, doesn't go back in, what do you have? Sustained full body muscle contraction. You go with that? Okay, let's do the last part. I have sustained muscle contraction. We talked about exercise. What is my body doing? You guys know you get hot when you exercise, right? Why do you get hot? Your big muscles are working and you're using ATP and degrading it to ADP, AMP, and preadenosine. Remember, breaking those high phosphate bonds, energy is created, but what is also created? Heat. That's right. So that's why the hyperthermia exists. That's why it is hypermetabolic state. All right. So now I'm burning lots of ATP. What is my body going to do? Try to create mitochondria is where ATP is created, right? What is my body going to do? It's going to try to create more ATP for my big muscles. So I'm going to use more oxygen. And then you said in the back, what is the byproduct, right? When you use your car, you put gas in, what is the byproduct that comes out? Whatever comes out of the tailpipe, right? In this case, oxygen goes in, CO2 goes out. And if we're using this machine more to a greater degree, what is the amount of CO2? Higher, which is another reason that when you exercise in an extreme way, you breathe faster, not only to suck more oxygen in, but to get rid of more CO2. Okay? So there's your, we talked about rigor. Rigor, all that means is muscle contraction. Heat, we talked about heat. We talked about creating more CO2 because of the hypermetabolic state. In order to create cellular energy, you not only need oxygen, but what do you also need? Substrate. And you also need, glucose, glycogen, in order to create cellular energy. Well, you guys know, right? You guys remember from physiology, aerobic versus anaerobic metabolism. Aerobic metabolism with oxygen, body's incredibly efficient at creating ATP. However, when my oxygen debt gets so high that all of a sudden I convert to anaerobic metabolism, meaning they can't stop. And at some point, the oxygen debt is so high, there's not enough oxygen to create more ATP. The body becomes inefficient. Look what it starts to create. Lactate. What is lactate? It's acid. It's acid. So acidosis, you've heard of acidosis, right? And acidosis, lactate levels that are higher and higher, acidosis that is higher and higher when untreated will lead to death. That's right. So now you know everything you need to know about malignant hyperthermia and why it occurs. Does anybody have any questions? So if you can remember the diagram, you don't have to explain this to your friends at parties, it's fine. But if you can remember the diagram, you know why in a MH situation, people develop muscle tension and rigor. You understand why people can develop hypoxia. You understand why it's malignant hyperthermia. And you know why that more CO2 is created. Are we good? All right, so who is susceptible? And so someone said this is genetic and you should remember that for your testing. So it's genetic, right? It runs in families. I don't want you to memorize the incidence, and I'll tell you why, because no one knows the exact incidence of malignant hyperthermia. It's pretty rare. However, there are particular areas of the country where it's significantly more common. Why would that be? Think about Los Angeles, right? We're in LA. How many different types of people live here? A lot, ton, right? However, in certain areas in the country, if MH is prevalent in terms of the genetics, and those people are the ones that continue to spread the genetics and live in a small group, do you see how it's much more likely to be passed down in that group, in that small community? So there are, not for you to memorize, but there are communities where MH is more susceptible, not for any other reason, in that it is a small community, the genetics exist, and those people, procreate, and the same genetics are there. All right, so we don't know what the incidence is. You may never see this in your career. Has anyone yet helped? You guys are in clinical yet? Okay, good. Have any of you seen this? Nice. Can you tell us a little bit about your experience? I'd love to hear it.
It was already predicted. It was a 13-year-old with muscular dystrophy. So they already knew that he was at risk.
They already knew he was at risk. Good. So what did they do? What did you do with the anesthesia tech?
We just removed the SIBO and the sucks from the room.
Yeah. So you remove the SIBO, can't give it. You remove the succinylcholine, can't give it. So there's no way to make that mistake, right?
And wheeled in the MH card.
And we had the MH card available. Good for you. I love it. All right. The best way, so what they did was they knew that there was the potential and they avoided it, right? The best thing to do is to know and avoid it. We can provide a perfectly good anesthetic without inhalation agent and without succinyl choline. And if you don't give those two, the disease state is triggered by those two, the disease state doesn't occur. Good. Well, did the kid do fine?
Yeah.
Yeah, good. All right. So you said they knew. They knew, and I'm going to go over some people who may be at higher risk, but this is important stuff for you to know for your tests and for your boards. I just said we'd prefer to prevent this as compared to it occurring and treating, right? Makes sense? So if you guys, I don't know if Tony or Sarah or you guys in clinical have been going to pre-op. Do you ever hear the anesthesia people in pre-op say, we say this every time, have you or any of your family members ever had problems with anesthesia? Have you heard that? Okay, good. Why are they asking that? Why are we asking that? You guys too. Why are we asking that? It's for the hell of it.
Contraindications, just like get a sense of someone's history, if at all.
Good. So for instance, let's say the patient says, my dad had trouble breathing after anesthesia. That could be a million different things, literally a million. It tells me nothing about that guy, the patient. However, what if the patient said, and remember, most patients don't understand the medical stuff that you understand. What if the patient said, you know, my dad had surgery, 10 years ago, and afterward he developed a high fever, which can happen, right? But the anesthesia people told him that, he has to be really careful with having anesthesia in the future because the temperature could come back. That's like a holy crap, right? So do you see how you can go from very non-specific to specific? Now, with what the guy just told me, I don't know if he has MH, but am I going to take a chance? Absolutely not. I am not going to give him an inhalation agent, and I'm not going to give him sucks. Period. End of story. I'm not going to take the chance. Make sense? So pre-op eval is one way that we can pick up, is someone possibly MH susceptible? But, that's subjective, right? Okay. Is there an objective way to test for this? And it is. And this is in red, what you need to know for your tests and for your boards. There's something called a caffeine halothane contracture test. It is only done at a very small handful of labs across the United States. What a surgeon will do is take a small muscle biopsy from the patient, and they'll take the muscle, and a scientist will put the muscle in halothane, which is an old inhalation agent, and caffeine. And what they'll look to see what is the degree of muscle tension when you put that muscle biopsy in that concoction. If all of us are in this box, meaning I take muscle from you and it contracts that much, and I take muscle from me and it contracts this much. If this box is normal, someone who is MH susceptible, their amount of contraction, this is normal, their amount of contraction may be out here. And therefore, that test would be positive, saying that they are MH susceptible. If we have documentation, there's absolutely no way we're giving inhalation agent. There's absolutely no way we're giving succinyl choline. Make sense? Last thing. In the future, there is a genetic test for MH. It's not perfect yet because they don't know all of the genetic malformations that are associated with MH. So there are still false negatives associated with it. In the future, it'll become so good that we can do a blood test and then get that back and then see yes or no. Okay? So do you understand what we just talked about? Pre-op eval, not specific. Caffeine halothane contracture test. Muscle biopsy, degree of stretch in a lab. last genetic testing to see if someone has that genetic code. As you said, it's a genetic disorder. It works, it's good, but it misses sometimes because they don't know all of the genetics that are associated with MH. We good? Here is what you were talking about in your patient. So who is at risk for developing MH? MH is a muscle pathology. It is a genetic muscle pathology. However, they believe that MH is associated with other muscle pathologies such as these, and muscular dystrophy is a big one. What did you say your kid had?
Duchenne.
Say it again?
Duchenne.
He had Duchenne's. So look here. I put Duchenne right there for you. That is something you should know for your test for your boards. That's going to be on a test somewhere. Huh? But I just want you to know, clinically, there are other muscle pathologies that are associated with MA, not just Duchenne. Okay? Do I want you to memorize all of them? No. Do I want you to know Duchenne muscular dystrophy? Yes. And one of your classmates actually had that experience. That's awesome. Good. And you heard from him, when you work smart, things usually go perfectly fine. It's when you do dumb stuff that you harm patients, right? All right. This is easy. You guys know this. You told me this 18 times. Rarely does physiologic stress cause MH, but are triggering agents, so you know these two in red, right? I want you to know in red. Now, nitrous oxide is an agent that can be given by inhalation. And does nitrous oxide on its own stimulate the possibility of developing malignant hypothermia? No, it doesn't. So nitrous oxide versus the inhalation agents are different chemical structures. It's the chemical structure of the inhalation agent that they believe causes MH. So if it comes up on a, these days, very few people are giving nitrous oxide with general anesthesia, but academically, I want you to know, you see how that's a nasty test question? Oh, you can't give inhalation agents. Well, nitrous oxide is given by inhalation. Can you give that? And the answer is yes. Okay. So clinically, not that significant because we don't give a lot of nitrous, but it's a really good test question, isn't it? You talked about this. Hypermetabolism caused by sustained muscle contraction. Read those. Are we good? Read them? Good. I'm going to go to the last one or the last two. So when you guys exercise, because you say you do, right? You get sore the next day. Sometimes if you lift heavy or do something that you haven't done, right? What is the soreness from? It's from the lactic acid buildup. But what you've also done is you've destroyed muscle in that area that has been destroyed and is going to heal. That's part of the process of working out. And muscles grow that way. Now, MH, not normal. When you have sustained muscle contraction that doesn't stop, you start breaking muscle down. Make sense? As you break it down, bad stuff happens. And I'm not talking about breaking it down like I did a chest workout, my pec hurts a little bit. No. I'm talking about breaking down lots of muscle in your body. Remember, this MH is not going to discriminate between muscles in my bicep and muscles in my leg. It's going to take care of all skeletal muscle. Therefore, muscle will be broken down. When you break down lots and lots of muscle or any amount of muscle, something called myoglobin is part of muscle and it gets into the blood. Usually you just pee it out, right? If you do a good workout, no big deal. However, if you break a ton of muscle down, myoglobin can actually clog the kidneys and cause renal failure. So we'll go over other complications associated with MH. Renal failure is one of them. In addition, what do you know inside a cell as compared to outside of a cell? What is the amount of potassium inside a cell as compared to outside of a cell? Inside, the concentration is higher or lower as compared to outside. Inside, the concentration is higher or lower than outside the cell. Significantly higher inside of the cell. So all of a sudden, I'm breaking down lots of muscle cells. As I'm doing that, what do you think can happen? Hyperkalemia, I love the fact that you use the correct medical term. Hyperkalemia, high blood potassium. Okay, are we good? And CPK is just a breakdown product of muscle. Don't worry about it. All right, here is important. So remember we said, what is the most important thing to do is to identify it as quickly as possible. If we'll have some time. You'll want a break. You'll come back. I have iPad Vitals to show you. It's really cool. I'm going to have you diagnose MH on looking at EKG, pulse oximeter, that kind of stuff. So we'll do that. Not all MH starts out rip roaring, right? Meaning that if you started exercising dramatically right now, everything goes up, right? CO2, heart rate, blood pressure, all of it quickly. But it doesn't have to. So sometimes MH is difficult to diagnose because sometimes the signs and symptoms are very dramatic quickly, and sometimes they're much slower in terms of their onset. Does that make sense? Right. There are two things in red. Oh my goodness, maybe you need to know those, right? So someone said in the back, how do you diagnose this? Did I ever talk to you about diagnosis? And it's not like you're going to be doing a lot of this, but you may be helping. So if you go to buy a car, do you buy the car and go, oh, it's a pretty blue, I'm buying it? No, you check to see the safety record of the car. You compare prices of cars that are the same. You look at all the features of the car, meaning that you look at a lot of different data points before you make the decision, I'm buying that car. Make sense? Same thing here. If the CO2 goes up a little bit, is it probably MH? No, CO2 goes up for a number of reasons. But if the CO2 continues to go up in an abnormal way, and we have other signs and symptoms, meaning we have other things that point us to that diagnosis, then we need to make the diagnosis of MH. Does that make sense? So no one's going to go, oh, the CO2 is a little high, they have MH. No. We're going to look at other things first. But if other things start to happen, then we start to get suspicious of its MH. All right. Why does it say rise in end tidal CO2 most reliable and increased heart rate first sign? Any ideas? Any thoughts? Yes, please. So these are both in red. These both happen, right? These are both initial signs. But it says rise in end tidal CO2 is the most reliable, whereas it says increased heart rate is the first sign. So what is the difference there between most reliable and first sign? Why is it not increased heart rate the first sign or the most reliable sign? Let's see. Yeah, do you have a thought on that?
Yeah, increased heart rate can be many things. So it's not like you know, you see increased heart rate and you're like, oh, malignant hypothermia, right?
Right.
In order, so if you see increased heart rate, like that's abnormal, the second best way to like, or like the best way to like actually follow up on it is to check the end title.
Good. So I like the fact, so the first part of the question, there are many things that can increase the heart rate, right? If I had you sprint to the back and front 3 times, would your heart rate jump? Yes. Would your CO2 be significantly elevated? Because it's going to take you about 20 seconds to do that. Is your end tidal CO2 going to be significantly elevated with 20 seconds of really hard physical work? No, not at all. It's 20 seconds and then it's done. So first sign, increased heart rate of hypermetabolism. You were gonna say something else. Can you go to the most can you talk about CO2 as the most reliable sign?
I was just gonna base it off what you said, maybe less things cause a rise in end tidal CO2.
Good, okay. So we already saw the pathology, right? Muscle contraction, byproduct breakdown of creating more cellular energy, CO2. Are there lots of reasons the CO2 can go up? Not nearly as many as the heart rate. So, anesthesia technologists, I'm cluing you into something. Is there a reason? You guys are in clinical, you should know the answer to this. This is one of the things we would check immediately if we saw our end tidal CO2 going up. Is there something, anesthesia technologists, that would be significant and say the end tidal CO2 is going up for a specific reason that you guys know because you guys touch it every day? That's exactly right. So one of the things we're going to look at immediately is our CO2 absorbent exhausted? If it is, does this make sense? Yeah, it does. And if we change the CO2 absorbent and this comes down and we only had this, we feel much better. Okay, so good, CO2 absorbent. Anybody been in a laparoscopic case, watch laparoscopic surgery? Anybody see that? Belly full of CO2 gas? Not yet. It's CO2. They put gas in belly, CO2 in the belly. That can be absorbed also in the blood and raise the CO2. But as I'm going to show you when we get back, CO2 goes up a little bit. My granules are good. I'm just going to increase the minute ventilation. I'm going to make them breathe faster. Good. Goes up a little bit more. I'm going to make them breathe a little faster. But when we start to see it march up and up and up, and then we start to see an increased heart rate, and then maybe an increased temperature, now it's not like, now it's like, holy boy, I got to figure this out. And we'll talk about one way that will help anybody figure this out in a little bit. Okay? Are we good on that discussion? I want you to know this, and you guys already talked about, I want you to know what's in red. You guys already talked about that. Are we good? All the other stuff. Oh, yeah, see, I put it on, good. So what is the physical part of the anesthesia machine? You answered that. What is it? CO2 absorbent. Good. And then all the other stuff. But I really want you to know those first two. Are we good? Look at this. Initial signs. Well, we just said initial sign is increased heart rate. Well, looking, that's pretty big. Initial, that's 30%. But in the books, it says the initial sign is tachycardia. But this table is saying, oh, people can develop muscle rigidity as the first sign. People can develop fever as the first sign. What is that? Ready? Human physiology does not read the books. Just because the books say this is the first sign, in some people, it's not the first sign, which makes diagnosis more difficult. If this is the first sign, Are these things gonna occur soon after? You bet they are. Okay? So we can't look at physiology and look at a book and go, well, the book says this is the first sign. Because sometimes human physiology doesn't read the text. Does that make sense to you? Which is why we need to know all about the disease state. We need to know about all the signs and symptoms so that we as detectives can say, huh, that's abnormal. Let me look at other things. Oh, look, those two things are abnormal. In addition to this, I may have a problem. Yes? Okay. Treatment. If this happens, this is an emergency. Has anybody been in an emergency in clinical yet? Anybody been involved in it? Oh, can you please tell us? It doesn't have to be MH, just tell us.
Had a code airway
Oh dear, so a failed airway in the OR or somewhere else?
in the OR,
Okay, so,
ended up being just, they canceled it after we ran all the way across the.
okay. Do you know what happened?
No, we don't know.
Okay, all right. Was anybody in the OR when a crisis happened? Yes, so let's hear both of you guys. So you start. Yeah,
There was a bronchospasm in the
Right.
acute,
all right, good.
to saturate really fast.
Yeah, and do people, does everything get serious when patients desaturate? Oh, yeah, good, all right. What was your situation?
I think they were doing like a laparoscopy or something,
Uh-huh,
like they nicked an artery.
I hate when that happens.
So then I think they cut the patient open and then they like infused like
Yeah,
the tech had to set up a Belmont machine.
good, good, yeah, so that's hemorrhage, there's your crisis is hemorrhage. His is hypoxia and yours is hemorrhage, right? Let me ask you guys a question. When the patient started bleeding, when the patient got hypoxic, was there one person that took care of the patient? No. When there's an emergency, we don't take care of a patient with one person. We need multiple people. You had to set up a Belmont. Others were doing other things in order to help that patient. If we believe it's MH, it is not, it is a team sport. Make sense? You declare an MH emergency and everything stops. If we're giving sucks or inhalation agent, what do we gotta do? Stop. All right. Now, okay, sucks is good, would be given once at the beginning, so we're not gonna give that, continue to give that. But I turn the inhalation agent off. I think he's got MH. I turn it off. But then there's still SIVO in the machine. How do I keep that from getting to the patient? Any ideas? Yes,
Do oxygen flush?
you can do oxygen flush, but you're gonna have to ventilate the patient. And as you flush that, that is also gonna go to the patient too.
Oh, take off the mask first.
Okay, so the patient's intubated. So are you saying flush the machine? And how long are you supposed to flush the machine for? What do they say as a technologist? Flush for 20 minutes. Yeah, a long time. What am I gonna do for 20 minutes? Right, yes.
I've seen them put like the charcoal filters on.
Oh, you've seen them put filter? You've seen them filters? There are filters for MA? Yes, good. Here they are. I'm gonna pass them around. If you come to Kaiser and Sarah is gonna go over the MH cart with you, right? In our MH carts, we're gonna talk about dantrolene in a second. There are these charcoal filters. As you pass them around, try not to pull them apart. One says inspiration and one says expiration. So one's gonna go on the inspiratory, one's gonna go on the expiratory lead. What it is going to allow is inhalation agent to come out of the patient, but no more inhalation agent to go into the patient. If you see the diagrams, the concentration of SIBO will fall almost within 2 or 3 breaths. Good for you. So these are charcoal filters. So you. Stick around. How much do you think those cost? Nope. $60. They're not expensive. They're not expensive. Okay. All right. So here, we'll go over MH protocol in a second. 100% cooling. Does everybody understand up to dantrolene? Read what you're seeing. Does everybody understand up to dantrolene? Okay. We're gonna go over dantrolene in a second. I want you to know something. I'm not big into memorizing doses, but I do want you to memorize what's in red in terms of a dose. You know why? Because that's gonna be on a test and it's gonna be on your boards. Question, how many people, I teach this all the time, to you guys, to my anesthesia students, so I know 2.5 per kilo up to 10 milligrams per kilo, not a problem. How often have I given dantrolene in my career? Once I helped 15 years ago. So if you don't review this in 15 years, you think you're going to remember 2.5 milligrams? Absolutely not. So what I want you to do for tests and for boards is I want you to remember this. Everybody, no matter who they are, gets an initial bolus. What does bolus mean? What does that mean? You guys know what that means? Rapid injection of 2.5 milligrams per kilo. Doesn't matter what the kilogram weight is. Why? Because scientists have determined that that is the minimum dose needed to start treating malignant hyperthermia. If you give less, it's not going to work. So remember 2.5 per kilo. If it's working, you can go all the way up to 10 milligrams per kilo. Trivia. How long do you think it starts? Do you think it takes dantrolene to start working? How long? Start. 6 minutes, which is pretty fast. Okay. Hold on, let me take it. All right, here, let me go to this. Remember this slide? How do you think dantrolene works? How does it work?
Does it allow for calcium uptake for the SR?
It does, but in a specific way. You're exactly right. If that's a disease process, it allows calcium to go back in. But what is causing the calcium to come out? RY, the ryanodine receptor. So dantrolene, lipid soluble, goes into cells, into muscle cells, desensitizes the ryanodine receptor. The sensitization is what caused the disease state. By desensitizing it, it allows calcium to leave the muscle and come back into the sarcoplasmic reticulum, decreasing muscle contraction and reversing the disease process. Does that make sense to you? If you can explain that to your friends at parties, that's fantastic. No one's going to ever ask you that question, but I want you to have a conceptual understanding of why the hell are we giving this, right? All right, treatment. Blah, blah, blah. So you should read through everything that is white. Now, remember I said to you, this doesn't happen often. We don't treat this. When it does happen, the signs and symptoms aren't always obvious. Kind of scary, huh? In the United States, it is funded by the US government 24/7, 365 days out of the year. You can call this number, phone number, 1-800-MH-HYPER. That's the phone number. And what you will do is you will get an expert in MH on the phone from the Malignant Hypothermia Association of the US. We call it MHouse because we're too impatient. Okay. You can say, hey, I need some help. I'm a nurse anesthetist or an anesthesiologist or an anesthesia tech. I need some help. They will stay on, it is free. They will stay on the phone with you. They will listen to signs and symptoms. And if they believe that it is MH, they will stay on the phone and help you treat it. So there is no reason to not know how to diagnose this and treat this, even if you hadn't seen this in 25 years. Does that make sense to you? Okay, on the checklist, which I'm going to show you, you're going to see on the checklist, there's M-House. You should know, I don't care if you know the phone number, but you should know M-House. It's in red. You should know things are in red. Any other questions? Yes, please.
The Q 15 minutes.
Every 15 Q, yeah, sorry. Thank you for telling me. So remember they developed acidosis. Remember they developed hypercarbia. Remember they developed hypoxia. So an ABG and then, yeah, acidosis, hypercarbia, hypoxia. An ABG, as we're giving dantrolene, is going to allow us to see the process getting better. The amount of oxygen after 15 minutes of dantrolene should be higher. The amount of CO2 should be lower. The degree of acidosis should be less after I'm treating. That's an objective way to make sure the patient's getting better. Does that make sense? Thank you for this is, I don't need you to memorize this. If people get hyperkalemic, these are things we can do to combat hyperkalemia. We talked about they can develop renal failure. And when you guys exercise, you sweat, you lose fluid. Yeah. So guess what? People are going to need fluid. They're going to need IV fluid. You're going to want to make sure they're peeing. So don't memorize that, but there's a certain amount of urine we want to see. That's it. Okay. See, there's a lot in red here. What does red mean? Red means you should know it. Okay, so Tony or Sarah may have you calculate this, and I want you to know some stuff about dantrolene. And then I know I wrote it all out this time. It's all there for you, but we'll go over it. All right, a couple things. So what is dantrolene? Dantrolene is the antidote. It is the antidote for malignant hyperthermia. So we can decrease the amount of inhalation agent going to them. We can cool them. We can give them IV fluid. We can treat hyperkalemia. Nothing reverses the disease process that I've just said. Nothing. The only thing that reverses the disease process is dantrolene. So in the cart, in the anesthesia MH cart, you're going to have those filters. You will have cold compresses or cold packs to put on the patient's chest, but you will also have dantrolene, the antidote. So once you've identified they have MH, what is the most important thing? Getting dantrolene in their blood. That's the most important thing. All right. Important for you to know. Dantrolene must be mixed with, this is a test question, board question. With what? Sterile saline, E5W, or sterile water. Like right there. Right. And so why sterile water? Because the drug itself will, I have dantrolene, I'm going to pass it around. It will precipitate. It will become crystallized. So you must use sterile water. Will you remember that for a test? Should you remember that for a test? All right. Yeah. And there's a new product that I'm going to get to in a second. All right. This is in red. So you may have a test question on this. So it's going to ask you, how much dantrolene would you give initially to a patient who's 70 kilograms? So what is the initial IV bolus dose of dantrolene for everybody? Everybody, let's hear it. 0.45 milligrams per kilo. Good. So if we take 2.5 milligrams per kilo, the loading dose, multiply it by a 70 kilogram guy or girl, you get 175 milligrams, right? All right, now, we have two preparations, and I'm gonna go over this in a second. Actually, I'm gonna go over this right now. We have two preparations. We have one called Ryanodex. We have one called either Rabinodo or Dantrium. All three, there's actually another preparation. All three preparations are the same chemical. They are all dantrolene. The difference between this and this is not the chemical, is the concentration in this vial. This vial, the big vial, there are only 20 milligrams of dantrolene in this vial. I gotta give this patient 170, let's say 180 milligrams. There are 20 milligrams in this vial. How many of these do I have to mix up? 9. I have to mix 9 of these up just to give the initial bolus. That's gonna take time. Now, same drug in this one vial, 5 cc's. I will reconstitute with 5 cc's. In 5 cc's, there are 200 milligrams. How many milligrams do I need to give? 175, 180, like that, right? Like that, right? Do you see how I can put 5 cc's of saline, take this up, pull it out, each 1 cc will be 50 milligrams. Don't worry about this now. 50 milligrams, meaning that if I give 4 cc's, I'll give you 200 milligrams, and I can almost instantly give the loading dose. Kaiser has gone to Ryanodex. This has gone the way of the dodo. At some point in time, they won't even make this anymore, this preparation. It will only be the high concentration of Ryanodex. The advantage, you can give this so much faster as compared to trying to mix 9 of things. Does that make sense to you? All right. We'll go over the preparations. Okay, let's go over this. Let's see this. So how many, you came up with 9. Says it on there, but you came up with 9. All right, so 175 milligrams is what I needed. So now the question is, how many vials of this? 175 milligrams divided by 20 milligrams in a vial. 9 times 2 is 18, add a 0. So it's 9 vials is about 180 milligrams. Pretty much what I need to give. Are we good on the math? Do you understand that? Do we need to go over that again? Because I can. Are we good? Yeah, oh, we're good. Okay, good. All right. So that's one calculation for the big vial, for the non-concentrated vial. Look at Ryanodex. The difference, each vial has 250 milligrams, not 20. So if I need 175 milligrams, what I'm going to do is divide that by what? Divide that by 5. And therefore, 4 milliliters is about 200 milligrams. That's it. And I can give that really quickly. Makes sense? Let's look at the preparations. Here they are. Worried, but here they are. So I was just here. Let me pass this around. Don't break my. The vials are very, they're very hard. So that's mixed. This is the same stuff, and this is Ryanodex. To take a look at the concentration. So I'm passing around Rabinodo, and I'm passing around Ryanodex. I don't have dantrolene. Notice, are all the chemicals the same? Is this all dantrolene? All dantrolene, the same chemical. What is different? Concentration. Look, 20 milligrams, 20 milligrams, 250 milligrams. An initial bullet, they were using someone who's 140 pounds, which is about 6 kilos. They're saying 8 vials. 8 vials, 1 vial. Look at the amount of fluid that you need to mix. Remember we said each of these vials is mixed with about 50 to 60 milliliters of fluid. So I need to get a half a liter of fluid in order to mix the old stuff as compared to 5 milliliters of fluid to mix the new stuff. It ain't cheap, as you can see on the bottom. Dantroline's expensive. Usually it sits there. Usually no one uses it. It expires, and then we get new Dantroline. Okay? I had a student years ago say to me, well, doesn't that seem like a waste of money? And I said to him, well, you know, you paid for the airbag in your car. Have you used it yet? Like, no. I'm like, what if you need to use it? He's like, yeah, I guess it's a good idea. Okay. It is, if in the United States, it is a mandate, if you are providing general anesthesia, you must have either Dantrolene on site. You must be able to get Dantrolene, like if you're a standalone surgical clinic, that there, you must be able to run across the parking lot to get Dantrolene from the hospital. You can't not have this. And I'm going to tell you at the end why you can't not have this. You must have this available. Any questions on Dantrolene? Are we good? All right, differential diagnosis. So could it be something else? What if someone develops, what if someone has a ruptured appendix? Will they be tachycardic? Yes. What does tachycardia mean? High heart rate. Will they become hot? Ruptured. They're going to become septic. The people who become septic, when you get an infection, you become hot? Yes. So do you see there are other disease states that can mimic MH? So we call that figuring out what is the problem, differential diagnosis. Okay. And again, that's not really part of what you do, but I want you to know that when you're standing there listening to anesthesia people talk about, could it be this, could it be that? What they're doing is differential diagnosis. Look at this, mortality. Mortality before there was Dantrolene, and I would, just so you know, I'm old, but I'm not that old. Dantrolene came out in the 70s, but before Dantrolene, they didn't have it. Mortality rate with no Dantrolene was 70%. That's horrible. I work at Kaiser West LA. Our old chief of anesthesia was actually had many years ago a pediatric patient who developed malignant hyperthermia before they had Dantrolene, and the kid died. This is 30 years ago, 40 years ago. So it's real. Notice the mortality rate these days, pretty low. Why? Dantrolene, training. M-House, probably also. Yeah, and you can see mortality has gone down, which is good. Post-op concern. What is recrudescence is a big word, meaning it comes back. So let's say someone has MH. Treat it with 6 milligrams per kilo of Dantrolene. Taken to PACU, and an hour later, you're like, bye, discharge. No. They have to stay in the hospital for an entire 24 hours at minimum. They will be getting Dantrolene for the next 24 hours as an IV infusion. Because even though you initially treat the disease state, within that 24 hours, it can start to happen again. So this patient is not going to go home. They're going to go to the ICU. They're going to be monitored. They're going to get an infusion of Dantrolene. Does that make sense? Hemodynamics, we're concerned about their heart. We're concerned about their brain. I already talked about renal failure, right? They can develop renal failure. Here's one last one. You guys have probably never heard of the term, have you ever heard of the term DIC?